It's true, nitronox is back. And because we have some new providers and residents here at McGee, I thought I would do a quick video to review the properties of nitrous. First of all, it's a colorless, odorless gas that has good anxiolytic and some analgesic effects. We use it in a 50-50 mix with oxygen. It is a liquid at room temperature. It is self-administered by a demand bivalve mask, which requires inhalation force. And then the exhaled nitrous is scavenged. Keep in mind that it rapidly crosses the placenta. When being compared to an epidural, nitrous oxide has variable pain reduction and good anxiolysis. It is non-invasive, and the woman has the freedom to move about, although here at McGee, we do have a policy that they must remain in their bed while using the nitronox. Although nitrous may be new to us at McGee, it is not new as a labor analgesic. It's been used since 1881. In 1930s, it was used with a minute apparatus with concentrations as high as 80%, and it fell out of favor with epidurals in the 1940s. It is commonly used worldwide, even more so than regional anesthesia. It could be used as a bridge while waiting for an epidural. It could be used for manual placental extractions and other procedures, such as difficult episiotomy repairs. It could be used for patients who are trying to avoid epidural use altogether or who are laboring rapidly. And it could be used in triage deliveries or in other settings when an epidural is not available. Before we use a medication, the first question we should ask is, does it work? There was a study done in 2017 by Richardson. This study showed that 40% of patients who originally said they only wanted nitronox eventually got an epidural. Fewer individuals said that their anesthesia had high effectiveness in the nitronox group. However, satisfaction scores were equal. Is it safe for mom to use? Studies have shown that it does not affect uterine contractility. There's no urinary retention or malignant hypothermia. Hypoxia was not seen in studies. There's a half-life of only 5 minutes. There are no known effects on breastfeeding and no increase in falls. A study in 2016 showed no difference in obstetrical complications or difference in APGARs or in duration of labor. Another retrospective study of over 6,000 patients showed again that 42% who had randomized to nitronox use ended up getting an epidural anyway, and there was a slight increase in chorioamnionitis and C-sections in the epidural groups. The next question is it safe for the fetus? First, we have to review some basic science safety information. Nitrous is known to inactivate vitamin B12 permanently. It is a methionine synthase blocker, which causes an increase in homocysteine. It's an NMDA receptor antagonist and has epigenetic effects. Is this true in our labor setting? We don't really know because we only have data for 70 to 100% nitrous use, not 50% that we use clinically. How does basic science information translate to clinical effects? In 2009, Wilder et al. Showed that 90 to 120 minutes of exposure prior to age 4, followed by a second surgery, which again exposed the child to nitrous, increased learning disabilities and ADHD with a relative risk of 1.59. Because of this information, there are some contraindications to nitronox use. If the patient has a current vitamin B12 deficiency or pernicious anemia, or is at risk for a vitamin B12 deficiency, such as those who follow a vegan diet, these patients would not be candidates for nitronox use. Also, patients who are acutely intoxicated, patients who have had a history of trauma or pneumothorax, patients who have increased intracranial pressure, or are unable to hold their own face mask. Side effects may include nausea, vomiting, dizziness, and dysphoria. Some of this information may seem overwhelming for the patients, but here at McGee, we do believe that it can be used safely. there is a consent form that must be filled out by the patient, which will review the risks. Keep in mind that the nitrous oxide concentration should not exceed 50%. It should be self-administered by the woman holding a mask to her face and not held by anyone else. And the equipment releasing the nitrous oxide should use scavenging. The consent discussion and signed patient agreement will be performed by anesthesia here at Magee. There will be no co-administration of other sedatives such as opioids, Stadol, or Benadryl. If the patient requests a switch to an epidural, you must stop using the nitronox for 5 to 15 minutes until alertness is regained. And again, there are certain patients that cannot use nitronox at Magee. Those who have a Category 3 or a concerning Category 2 tracing, those who are at high risk for cesarean delivery, any patient who has an indication for early epidural analgesia, any patient who has had a recent wet tap or dural puncture, any facial trauma or recent ear surgery, any known or suspected elevated ICP. Vegans have a 50% chance of a vitamin B12 deficiency, as do patients who've had a gastric bypass. Keep this in mind when selecting patients for nitronox, as nitronox is contraindicated in patients with known pernicious anemia. The last and newest complication is COVID. Nitronox cannot be used in anyone that has an airborne illness. I appreciate you watching the video, and I hope it helps you to make safe decisions about the use of nitronox in our hospital.